Welcome to this particular sequence of videos on airway basics. In this particular segment of videos, we'll be seeing on the basic airways. At the same time, we'll be discussing on a lot of advanced airways and advantages of one airway over the other, as well as the disadvantages of one airway over the other. And this is going to be very crucial for you people, especially if you're an emergency guy or if you're a casualty guy, and this one's for you. So please pay proper attention to this particular video, and this might be your future exam questions in a very relevant way, because the trend is getting changed into more of practical based questions, and I've introduced a lot of questions and a lot of images, a lot of videos in this particular section. So please pay attention and please understand this video much better. If you have any doubts, please post it personally to me so that we can discuss much better also. So let us move on without wasting much time. So first one we have to know whenever we discuss about this basic airways is on how to open up the airways. So opening up the airways is the key. There are two principal maneuvers how to open up the airways. The first one is the head tilt and the chin lift maneuver, and the second one is the jaw thrust maneuver, and each one has one advantage over the other. Let us see where you're going to use this kind of maneuvers. So let us go to airway opening maneuvers. So opening, as I told you, there are two maneuvers are there. This one is what we refer to as the classic head tilt and chin lift maneuver. And the second one is what we call it as a classic jaw thrust maneuver. So let us see the head tilt and chin lift first. So what the doctor does in the head tilt and chin lift is, for example, probably the dominant hand will be placed on the forehead. Probably it's not like always you should place only the right hand. So probably the dominant hand will be placed on the head, that is the forehead, especially the heel of the palm. So this is the area that will be placed on the head, so that they will try to push the head down, so that they will tilt the head down, or in other words you can tell they are trying to extend the head also. So tilt the head down, this is a head tilt. At the same time, the other hand, they use these two fingers predominantly, that is the index finger and the middle finger. Use these fingers to catch the chin of the mandible. So this is the chin, and they try to lift the chin up. So this is what we refer to as a head tilt and a chin lift maneuver. What you can see here is in this image exactly the same. The doctor is trying to push the head down towards the table. At the same time, they are using this fingers, index and the middle finger of the other hand to just lift the chin up, away from the table. So this is the classic head tilt and a chin lift maneuver. But one problem associated with this head tilt and chin lift maneuver is the fact that you can see the spine here. This is a cervical spine here, and you can see there is a considerable change in the position of the cervical spine whenever you do a head tilt and a chin lift maneuver, which means this maneuver cannot be performed in a patient with a suspected spine injury. So cannot be performed in a patient with a suspected C-spine injury. So you cannot do that because there is significant mobilization of the C-spine here, and there might be further damage of the C-spine if you do this maneuver in this patient. So don't do that. So next question automatically comes, when will you suspect a C-spine injury? That's the question. So again, it depends on history and examination findings. In history, one classic history that is always very, very important on examiner's favorite, which tells you that there is a probable cervical spine injury, is fall from height. Like for example, fell from stairs or in a road traffic accident again. So these are classic history where you should suspect this C-spine injury. And second, a lot of examination findings also can tell you that there could be a probable C-spine injury. For example, the patient comes with quadriparesis to you, so definitely you suspect a C-spine injury. Patient comes with respiratory paralysis, especially if they have very low tidal volumes because of diaphragmatic palsy, still you suspect a C-spine injury. And if they have significant bruising and tenderness or subcutaneous emphysemas over the neck region, and there is tenderness over the cervical spine, and the inability to move the neck here and there, and all these things will tell you that there is a probable cervical spine injury. Whenever you suspect a cervical spine injury, do not do this head tilt and chin lift maneuver. So let us move on to the jaw thrust maneuver. So jaw thrust maneuver is specifically designed for patients who are having suspected cervical spine injury. So if you think that this patient is probably having a C-spine injury, go for the jaw thrust maneuver, which opens up the airways. In the jaw thrust maneuver, you can see it's again a bimanual technique where the examiner keeps the thumb on the face, like this, especially on the zygomatic arch or near the maxilla next to the nose, they keep the thumb over here. And using either the other fingers as a whole, or they can again use these two fingers, the index and the middle fingers, to keep them on the angle of the mandible and just lift the angle of the mandible outward like this. You can see this outward like this. The mandible just moves outward. So this is what we refer to as a jaw thrust maneuver. So that's what exactly happens. You can see the position of the examiner's fingers over here. So you can see that they are using these fingers to lift the angle of the mandible forward. Clear? So this is what we refer to as a jaw thrust maneuver. So let us see in the videos how they are trying to do it. So this is a classic head tilt and chin lift maneuver where you can see he keeps the heel of the palm on the head and tries to lift the head down. At the same time, he's using the fingers to lift the chin up. So this is the classic head tilt and chin lift. You can see from the other angle also how he uses the hand to lift the chin up and open up the airways. Using the thumb, you can also try to open the mouth in this kind of maneuver. This is something like a modified thing, and this is also useful in these scenarios. So why opening of the mouth with the thumb becomes important is because you can remove objects that have been probably choked by the patient. At the same time, you can also do mouth-to-mouth resuscitation at the same time. So here he is looking for either some of the objects, if there is any, if they are present inside the mouth, and yes, in this case, if it's present, so they can take these objects out of the mouth so that you can save the life of the patient. So this is the classic head tilt and chin lift maneuver, right? Then let us see how you are going to do a jaw thrust maneuver. So in a jaw thrust maneuver, you can see here he's placing his thumb over the, in this case there is a mask, so that is keeping over the mask, otherwise it will be on the zygomatic arch. And he's just trying to use the fingers to lift the mandible up. He's pushing the angle of the mandible forward. So it's a very, very easy peasy technique. So this is what we call it as a jaw thrust maneuver. So in a suspected spinal cord injury, what you have to prefer is always the jaw thrust maneuver, and you would have understood in the jaw thrust maneuver only the angle of the mandible is manipulated, but the cervical spine is not manipulated. That's why it is the airway opening maneuver of choice in a patient who's having a suspected cervical spine injury. So let us move on to the next slide, and let us see what are the classification of the airways and what are the functioning of the basic airways. So how will you classify the airways? Or more than calling the airways, we can call airway devices, right? So let us classify the airway devices. So there are two types of airway devices. One is the basic airway devices. Second is the advanced airway devices. Advanced airway devices. The basic airway devices, there are only two basic airway devices. One is the oropharyngeal airways and second one is the nasopharyngeal airways, OPA and NPA. Oropharyngeal airways and the nasopharyngeal airways. Each and everything has their unique advantages and disadvantages, which we'll see in some time. And probably you have a lot of advanced airways also. Advanced airways can be classified into those that are placed above the glottis. These are referred to as supraglottic airways. Or even they are also called as extraglottic devices. Or supraglottic device is the right name, supraglottic airways. Or it could be transglottic devices. Transglottic devices, or probably third thing are the subglottic airways below the glottis. Transglottis means those are the airways that pass through the glottis and enter the trachea. Subglottic means they don't cross the glottis at all, but they will directly placed in the subglottic region into the trachea. Okay. The supraglottic airways are once again classified into laryngeal tubes and laryngeal mask airways. So we are going to extensively classify in the next slide, but before that, let us assume they are divided into two. One is called the laryngeal tubes and second one is the laryngeal mask airways. The transglottic devices are only one. They are basically the endotracheal intubation. So again, based on how you insert the endotracheal tube, it could be nasotracheal intubation or orotracheal intubation, where orotracheal is the commonly performed technique. We have a whole lot of separate video on endotracheal intubation. Fine. And subglottic airways are two types again. One is a cricothyrotomy or otherwise referred to as a cricothyroidotomy. Next is the tracheostomy. Remember, this cricothyroidotomy is performed usually only in emergency conditions. Like you cannot intubate at all. Only in emergency scenarios. There is a scenario called can't intubate, can't oxygenate. That's called a CACO scenario. Can't intubate and can't oxygenate in emergency scenarios. In those conditions only, you generally prefer a cricothyroidotomy. It is a type of a definitive airway only, but we don't perform routinely. But remember, this endotracheal tube and the subglottic airways, the transglottic and the subglottic airways are generally definitive airways. And the doctor will have a very good airway control, excellent airway control, which means the patient's airways will come completely under the control of the doctor, and whatever the doctor tells, the airways will respond accordingly. So you can manipulate the airways. So it's an excellent airway control. So which means the entire airways will come under the control of the examiners only. And with these airways, you have a very, very, very negligible risk of aspiration. Especially with endotracheal intubation and tracheostomy, there is a very negligible risk of aspiration. Very little risk is still there, but very, very negligible risk, almost zero. But remember, this basic airways are only for resuscitation purposes. Only you will use this for resuscitation purposes. These are not definitive airways at all. These are not definitive airways. You have to convert this airways to a definitive airway. And these airways pose a very, very high risk of aspiration, extremely high risk of aspiration if you don't address the other issues in certain time. Clear? But these supraglottic airways are somewhere in between. So they are not definitive airways also. At the same time, in certain scenarios, they can be used as the only airway. I mean, the oropharyngeal and nasopharyngeal airways cannot be the only airway. But these supraglottic airways in certain places, they can be used as only airways, but they are again not very definitive airways in lot of scenarios. But still, it's somewhere in between. That's what I'm trying to tell. Aspiration risk compared to this transglottic and subglottic devices, there is a little bit high risk of aspiration, but not like the oropharyngeal or nasopharyngeal airways. That's why I told you it's somewhere in between. So they still do have some risk of aspiration, but definitely more than your transglottic and subglottic airways. Clear? At the same time, they come somewhere in between. And nowadays, this laryngeal mask and all are so advanced. Their third generation supraglottic airways have come, like Baska mask and all, which itself can be used for anesthesia purpose itself. It is a replacement for endotracheal intubation. So they are thinking in that big term. So now there are a lot of improvements happening in the supraglottic airways also. Let us see in the next section how big is this world of supraglottic airways. But anyway, so basically, these are the three things, and you have to remember the supraglottic airways are somewhere in between the basic airways and transglottic and subglottic devices. Clear? So there are somewhere in between. Clear? Whether you use it as a definitive airway or not depend on what is your procedure and what is the status of the patient. All these things have to be taken care. Fine. So now let us see what are the basic airways. Basic airway devices. Clear? So I told you only two basic airway devices are there. One is going to be your oropharyngeal airway, and second one is the nasopharyngeal airway. Clear? So in this oropharyngeal airways, you can see they are very rigid tubes. They are very, very rigid. They are plastic tubes. Why? Because you are inserting into the oropharynx. You are inserting it through the oral cavity. So, and they have to be rigid because they are prone for biting by the patient. So once the patient bites, or if it's soft, means once it kinks in the oropharynx, means it's really, really difficult to ventilate the patient again. So that is the reason why they are very rigid. And since they are very rigid and they are placed through the mouth, there is a high chance of inducing gag reflex. So which means patient might vomit and they might aspirate their own contents also. That is the reason, if they ask you where you will prefer these oropharyngeal airways, you are going to prefer these oropharyngeal airways in patients with a very, very low GCS. In patients with a very, very low GCS, especially if the gag reflex is negative. Very, very important. The airway protein reflex are negative, then for resuscitation purpose, you can use this oropharyngeal airways. Clear? They are like PVC, rigid plastic tubes, and they are available in different sizes. So this is how you are going to select the size of the oropharyngeal airway. Here you can see they are placed near the incisor. Remember, incisor is a very good landmark. Incisors are a very stable landmark also in most of the patients compared to the angle of the mouth. Even though some books tell compare the angle of the mouth, the angle of the mouth is prone for deformity. They can be like this, they can be like this, but incisors are relatively more stable landmarks. So you keep the airway here, beginning here, and you place vertically down, and so that the airways should be reaching the angle of the mandible. You can see the airways here reach the angle of the mandible. So this is the right size of the airway for the particular patient. Suppose if it crosses the angle of mandible and goes, means then it's a very, very big airway, not suitable for the patient. If it's very small so that it doesn't reach the angle of the mandible at all, means again it's a very small airway, not good for the patient again. So this is how you select the size of the oropharyngeal airway. Remember, these oropharyngeal airways are also referred to as Guddel airways. Very important name. Then, so let us see how you are going to insert this oropharyngeal airways. First, remember, you should insert with convexity facing the tongue of the patient or facing the feet of the patient. So convexity should be facing down. So like that only you start inserting the airway. So it's actually opposite the oropharyngeal curve, but let me tell you why. So at one point it go and start hitting the palate here. So definitely it will start hitting the palate. Palate will not allow any more movement. So when you feel resistance at that point, which means you are hitting the palate, then try to rotate this airways to 180 degree. So you just try to rotate the airway to 180 degree so that it nicely and smoothly fits into the curve of the oropharynx. So this is how you place the oropharyngeal airway. Clear? So let us see the nasopharyngeal airway. Nasopharyngeal airways, on the other hand, are placed through the nose, so they are generally soft. I mean, they are not prone for biting. At the same time, you cannot pass a rigid tube through the, like nose and the nasopharynx. But nasopharynx is relatively larger, so the tubes itself will be descend in such a way, and it will be more softer compared to that of the oropharyngeal tubes, and they do not induce gag reflex. So that's a very, very important point. So that is the reason why nasopharyngeal airways are selected in patients with a reasonably good GCS, or in those patients who have a good gag reflex. In those patients, always prefer nasopharyngeal airway. Do not go for the oropharyngeal airway. But remember, one of the important contraindications for nasopharyngeal airway is your bleeding, epistaxis. Epistaxis and all will be, and head injury and all is a contraindication for nasopharyngeal airway. So for example, if you have an epistaxis or if you have a head injury, definitely this nasopharyngeal airways will be contraindicated. Do not use them. But you can use in other patients with a good GCS or in patients who are having a good gag reflex. This is a very good alternative. In my emergency department in the hospital, usually they go for this nasopharyngeal airways only rather than oropharyngeal airways. This image shows you how to select the size of the nasopharyngeal airway, where you can see it is placed from the beginning of the nose and it should reach the tip of the ear. At least some books will tell you the tragus, but anyway, it should reach the ear. That's all. That is the idea. So this could be the right size of the nasopharyngeal airways, and this is how you select the size of the nasopharyngeal airways. It is usually available from sizes 6 to 9 centimeter in case of adults, where 6 we will choose for small adult, 9 will choose for relatively larger adult. Okay, so this shows the insertion of nasopharyngeal airways. It's very smooth and straightforward. Just you are going to push the nasopharyngeal airway into the nose. But one technical point is there. There is something called a bevel. If you see very carefully, this nasopharyngeal airway has something called a bevel. You can see there is a bevel. So there is a slanted distal end is there, and the bevel should always face the septum of the nose. So that is how you start with it. So that's a very important point. That's a technical point that you have to know. Okay, now let us see how you are going to insert this basic airways through this particular video. So here first we'll see how you are going to insert the oropharyngeal airway. You can see now the convexity is actually facing towards the tongue or towards the base of the body. Once it hits the palate, it rotates the airway to 180 degree, and which will further result in smooth insertion. Now you can see the nasopharyngeal airway. You can see clearly the bevel is facing the septum. So this slanted end is called the bevel and facing the septum, and that's the only one technical point that you have to know. Otherwise it is smoothly inserted into the nose. So this is how you insert a nasopharyngeal airway. So this is like absolutely cool. So both are very easy to do it. So please note that down, because many times in practical exams and all, you will be definitely asked this particular kind of question, or even you might get this kind of videos in your exams as well. Okay. Now let us move on to the world of supraglottic airways. So this is a huge area, supraglottic airways or supraglottic airway devices. Supraglottic airway devices, as I already told you, they are divided into two types. So basically, for the first type is what we refer to as laryngeal tubes, and the second type, basically, we call it as laryngeal mask airways. So let me write laryngeal mask airways. So hereafter we will use the common term called LMAs or LTs, laryngeal tubes. Remember, these laryngeal tubes are usually has two seals are there, but the most important seal is the fact that they have a pharyngeal seal. I'll show you what do you mean by a pharyngeal seal. They generally tend to have a pharyngeal seal. Clear? At the same time, a lot of these laryngeal tubes will have esophageal seals also, which means they will have two cuffs. One cuff for the pharyngeal seal and another cuff for esophageal seal. Clear? So they have two seals, but the most important thing that classifies them is under the pharyngeal seal. So definitely they have that pharyngeal cuff and esophageal cuff. And there are two types of devices that come under this laryngeal tubes. One is the combi tube, the classic combi tube, and the second one is the King devices. King device, again you have LTD device and you have LTSD device. Clear? So there are only some subtle differences between this LTD, LTSD and combi tube. But remember, combi tube has two separate ports, one for esophagus and one for the trachea and one for ventilating the patient. But King device has only one port. But let us see how they are classified and how they are divided. Before that, going into the details of this combi tube and King devices, let us see how these laryngeal tubes generally work with the pharyngeal seal. So this image will nicely tell you how these laryngeal tubes are working. So this is the device per se. I'll shade it in blue for you. So this is the device per se. And you can see there are two cuffs. One is the pharyngeal cuff. This gives the pharyngeal seal. And the second one is the esophageal cuff. That gives the esophageal seal as well. So whenever you ventilate the patient, for example, you push air through this tube, the air enters into the tube and there will be an opening that is going to enter the glottis. So which means the trachea is ventilated now. So this is the mechanism of how all these tubes generally work. But even though there are some subtle differences between the tubes. For example, this is a combi tube and this is a King LTSD tube. So this is the advanced one, King LTSD one. So the basic differences, you can see two ports. So the one port is the ventilatory port. Whenever port number 1 always means a ventilatory port. And the second port means it's a esophageal port, which means that port will end into the esophagus. Which means what we are trying to do in this laryngeal tubes is we are intentionally cannulating the esophagus. You can see you are intentionally cannulating the esophagus. Fine. So once you have intentionally cannulated the esophagus, now you are sealing the esophagus to make sure that the contents doesn't regurgitate. At the same time, air doesn't go into the esophagus and unnecessarily inflate the stomach and cause increased intragastric pressure, which will prone for aspiration and Mendelssohn syndrome again. So you are giving a double protection. One, by inflating the cuff, at the same time you are preventing air movement into the esophagus also. And you can actually drain through this also. A lot of this laryngeal tubes have a provision so that you can drain the aspirations. If at all, if any content is there in the stomach, you can drain through this esophageal port also. For example, you have an esophageal port here, and a lot of laryngeal tubes have advancements in such a way that you can even insert a nasogastric tube through these ports. So once you insert nasogastric tube to these ports, you can even aspirate the contents out. So a lot of advances are there in this laryngeal tubes. Fine. So, but you might ask me one question. What if I accidentally place this combi tube into, this is a combi tube, right? So that's what we have been discussing. What if I accidentally place into the trachea rather than the esophagus? So because this, remember all the supraglottic airways, devices, one thing that you have to know, they are blind airways, which means you are inserting blindly. You are not having, like a proper evidence, which means in a tracheostomy or when you are doing a cricothyrotomy or when you are doing a endotracheal intubation, you know where the air, the device is going. For example, if you insert an endotracheal tube, you see the larynx and you see the glottis, visualize the vocal cords, and you insert the endotracheal tube into the glottis. But these are not like that. These are just blind airways. We don't see what's happening. The only evidence for a good ventilation may be a waveform capnography, which I'll tell you in the endotracheal intubation. But apart from that, we don't have much evidence, right? So that's why this is prone for sometimes. What if instead of entering the esophageal lumen, if it enters the tracheal lumen? So what will you do? So is there any provision? Yes. Combi tube has excellent provision. Even if you insert into tracheal lumen, you have provision for ventilating the patient. How? You can see this is the correct placement actually. This is the correct placement. Really, this is what the combi tube is intended for. You can see here the end of the tube is in the esophagus. So this is the esophageal area. End of the tube is in the esophagus, and this is the esophageal cuff. And you can see this is the pharyngeal cuff as well. Let me put it in blue. So this is the pharyngeal cuff. And whenever you ventilate the patient, so this is the port number 1. I told you through port number 1 is the port that is always for ventilation. That is what is destined for. So the air enters and it is going to leak out through the channels here and it's going to enter the trachea. The air cannot go into the esophagus also, not possible because of the cuff that is inflated, and air cannot leak out also back into the atmosphere because again this is pharynx is sealed. So it's a beautiful device again. So this is how the ventilation happens. So but my question is, what if you accidentally intubate the trachea, or if you willingly intubate the trachea, whatever. So in this condition you can see you have actually intubated the trachea in this condition, not the esophagus. Still, combi tubes provide some unique advantage that you can connect the ambu bag through port number 2 and you can still ventilate the patient through this second port, because second port will not leak, it will directly go into the trachea only. Still you can ventilate, and it also gives an additional advantage that you can produce a tracheal sealing also, like an endotracheal tube. So that's why it offers some combination of advantages. So that's why these are somewhere in between endotracheal tube and basic airways. So they perform a little bit this and that both. That's how it works. So combi tube has one unique advantage, that they can serve as ventilatory devices in case of tracheal intubation also. But King tubes doesn't have that provision. That's where the problem is. So let us see now. Let us compare and contrast. How will you differentiate these devices? First, we'll write combi tube here, and we'll write the King LT devices, and third one are the King LTS devices. What are the advantages? So is there any provision for ventilation if trachea is intubated? In case of tracheal intubation, tracheal tube placement, is there any provision for ventilation? Yes, definitely combi tube has that provision, but King LTD and LTSD doesn't have that provision. But one problem in combi tube is because these supraglottic airway devices are again designed to be used by paramedics as well as doctors. That's why they are somewhere in between. Remember, the transglottic and subglottic airways, this cannot be given to the paramedics, even though some paramedics do that in advanced level of training, but generally paramedics can't do that, the transglottic and the subglottic devices. Only the technical person, that is the doctor himself, can do that. But basic airways, definitely a paramedic can do that. But supraglottic airways, again in between, it is used by both doctors, professionals as well as the paramedics also. So whenever the paramedics are inserting the supraglottic airways, especially the combi tube, they might get confused. So number 1, number 2 port, which is going into the esophagus, which is going into the airways, and which is going to ventilate the airways, we have no idea. And the paramedics might sometimes get confused, and if he puts the ambu bag in the second port, he will be just ventilating the esophagus unnecessarily instead of the trachea. So that's why King LT devices have come. So King laryngeal tubes provide that advantage, but there is no confusion. Whenever you ventilate the patient, it always goes into the trachea only. But there is a esophageal port, separate this thing also. But let us see how these things work. So ventilation, instead of, in the case of tracheal cannulation, can happen only with the help of combi tubes. King LT devices can't do that. But is there any gastric drain? NG tubes can be inserted or not? You should not call NG tubes in this because you are inserting orally only. So is there any provision for esophageal drain? Combi tube, yes, they do provide the esophageal drain, but King LT devices doesn't, but LTSD devices have that feature as well. And can the ventilatory port, which we have been seeing, can it fit the bougie and the endotracheal tube? Can it fit into a bougie? Bougie means this is a director, so we used before endotracheal cannulation, isn't it? So can it fit into a bougie, or can it fit a fiber optic scope? That's what the question is. Fiber optic scope. Remember, combi tubes cannot fit a bougie or a fiber optic scope, whereas King tubes can fit a fiber optic scopes as well as a bougie. Whether can they fit an entire endotracheal tube through the lumen of the ventilatory port? No, none of this can support the endotracheal tube. Even a 6.5 tube cannot be supported. Clear? So this is one of the basic disadvantages of the laryngeal tubes. They cannot support the endotracheal tube through the ventilatory port at all. But they still can aid in intubation by supporting the fiber optic scope. For example, you can pass the fiber optic scope through this laryngeal tubes, and you can visualize the glottis and can go into the glottis, and you can take this combi tubes or King tubes out, and through the fiber optic scope which you have inserted before, now it is inside the glottis. Now through the same guide itself you can insert a endotracheal tube also. So possible. So it can guide intubation, but actually with the help of this device itself you cannot push the endotracheal tube inside the patient. So that is the one major disadvantage. Apart from that, these are the basic differences between a combi tube and a King LT devices. At the same time, you can see King LT device has only one pilot balloon. And again, there is no confusion. So one pilot balloon in the sense, by insufflating this balloon with air itself will result in insufflation of both the cuffs, that is esophageal cuff as well as the pharyngeal cuff. Clear? But on the other hand, combi tube is a little bit confusing. Again, there are two ports. Many times paramedics may not know which port will go into what, but anyway, there are separate ports which can inflate pharyngeal cuff separately, and there is a separate pilot balloon that through which you can inflate the esophageal cuff separately. So these are some of the basic differences again between combi tube and King LT devices. Fine. So now let us move on to the laryngeal mask airways. Remember, these laryngeal mask airways are commonly placed in the hypopharynx only. So I can write it as hypopharynx. That's where these laryngeal mask airways are placed, and you have to know that they create something called a perilaryngeal seal. But remember, your laryngeal tube devices are going to make a pharyngeal seal, but whereas this LMAs are going to provide a perilaryngeal seal to the patient. So let us see how these laryngeal mask airways work. Before going to the generations of laryngeal mask airways, let us see the basic functioning and anatomy of this laryngeal mask airways. So you can see this is the device for you, and remember, they may have a cuff, they may have a distal cuff, or they may form a mask-like structure without a cuff also. They are called cuffless devices. It can be with a cuff or without a cuff, but distally they form a mask-like thing that's going to form a perilaryngeal seal. So that's the basic anatomy. And the distal tip of the airway, the tip of this mask, it could be cuffed or cuffless, doesn't matter. The tip of this mask is going to be at the proximal portion of the esophagus. So this is the esophagus. So they're going to rest on the proximal portion of the esophagus. Whenever you ventilate this patient with air, so they will usually enter through a port in the mask, and they will be entering the tracheal lumen like this. So this is the basic functioning of how an LMA works. Clear? They provide a perilaryngeal seal. Either they can be cuffed or they may be uncuffed. So this is the real-time anatomy. You can see in 3 dimension where the mask, the real laryngeal mask, is entering the esophagus, beginning of the esophagus. So you can write this is the basic opening of the esophagus, and it's not actually entering into the esophagus like your laryngeal tube devices, but here it is at least at the beginning of the esophagus, right? So they provide a perilaryngeal seal. And you can see this is the respiratory tract. And whenever you ventilate the patient from here, so the air will be coming out of the mask and entering through the trachea. So this is the basic anatomy once again. So let us see how you are going to insert these devices. Very, very basic video. So this will show you the anatomy of the laryngeal mask airway. So remember, before inserting always, if it's a cuffed laryngeal mask airway, you should deflate the cuff, then only you should inflate. You should insert. After inserting only, it should be inflated again. So now they are doing some finger manipulation. Why? Because they wanted to insert it. So you can see they nicely fit into the beginning of the esophagus and they provide a perilaryngeal seal. And once you have inserted, you are going to inflate the cuff as I told you. But before insertion, if it's a cuffed LMA means definitely you should insert it, in the deflated position only. After inserting only, you have to inflate the cuff. That's a very important thing again. So this is the final portion. Again, I can show you. You can see the tip of the laryngeal mask is in the proximal portion of the esophagus and they offer a perilaryngeal seal. Fine. So now after knowing this, let us move on to the generations of the LMS. So this is the basic of the LMS. So now we are going to the generations. So you have first generation LMS. First generation LMA is a classic LMA. The first thing that you have to know is the classic LMA. And why this classic LMA is very important? Because this serves as a benchmark even now. Because it was first invented in 1982 by a doctor called Archie Brain. So he got the patent for this LMA in 1982. But remember why that name Dr. Archie Brain is important? Because he is such a good intellect that he is basically more of a designer of different instruments rather than an anesthetist. He is actually an anesthetist, a doctor, but he is more interested in designing these instruments. He has almost designed 12 instruments for ICU patients and in operation theatre before inventing this laryngeal mask airway. It's the 13th device he got the patent for. So it's such a big intellect, and laryngeal mask airways has been used over 300 million patients till now in the world from 1982 for various procedures like emergency intubation, failed intubation, then elective surgeries. Nowadays, elective surgeries are done under laryngeal mask airways. Daycare surgeries are done under laryngeal mask airways because they are a very good alternative to endotracheal intubation. For example, you don't need endotracheal intubation is more invasive and more problematic compared to that of laryngeal mask airways, which are simple to insert at the same time. If you are inserting correctly and if it's in the correct position, means it can provide excellent substitute to endotracheal intubation. So that is the reason why it has been used over 300 million times as per the 2017 data in the world. So that's why this name Dr. Archie Brain is very important. He has created a revolution in the supraglottic airways. Fine. Remember, the first and the next step you do after failed intubation is supraglottic airway device, which you'll see in the chapter of failed intubation again. So now classic LMA. So after this classic LMA, you have LMA flexible. Why they should have this LMA flexible? For that you have to understand what is the problems with the classic LMA and what is being addressed by the flexible LMA. So these are the two devices. This is a classic LMA and this is a LMA flexible. One problem that is there with the classic LMA is it is straight. It is not fitting the curvature of the oropharynx. Oropharynx is having a curvature. It is not straight. So to fit the curvature of the oropharynx, you need this classic LMA to be manipulated heavily, which means you insert the finger and you have to push the classic LMA inside. Clear? That's one problem that they have been facing. So that is the reason why they had this natural curved LMA. This is called a LMA flexible. So this is naturally curved with the help of some metal reinforcement so that it becomes rigid and it is curved and it is fixed in that position. Second problem what the classic LMA faced is, it is this body is relatively soft. It is not rigid. So at the same time there is no bite block. Remember, even in flexible there is no bite block, I will tell you that. So, but it's very soft so that if the patient bites, because this is the oropharyngeal device, so it goes near the perilaryngeal area, so through the mouth only. So the patient bites, they get kinked and airflow obstruction might happen. So that's why in LMA flexible, to an extent they address this issue. It become a relatively rigid device, not very rigid. Still they don't have a bite block. I'll tell you what do you mean by a bite block. Still, you don't have a bite block, but it's relatively rigid because of the metal string reinforcement. You can see very clearly, you can see the metal reinforcement on the body. So it is more curved, at the same time, it is having relatively resistance to bite. It's not a bite block, but still a good bite resistance is there in this LMA flexible. So these are some advances that happened with the LMA flexible. But remember, both are cuffed devices only. You can see the cuff, the perilaryngeal seal is achieved with the help of a cuff only. Both are because of, both have the cuff. So these are basically cuffed devices. So I can underline in pink, classic LMA as well as LMA flexible is cuffed only. But this cuff did provide some disadvantage, like sometimes you might result in extensive cuff pressure may cause problems like sore throat. Sometimes high oropharyngeal pressure might happen, tissue necrosis in the local area might happen. And to address all these problems, the third device came, that's called an AirQ device that came. I don't have the image for that AirQ device, but it's a cuffless device. So it is cuffless. You might ask me, if it is cuffless, how you can provide a perilaryngeal seal? The idea of this device is to provide this perilaryngeal seal with the help of a cuff. If you don't have the cuff, how they can provide a perilaryngeal seal? The idea of this device is they have created this in such a way that when you ventilate the patient, for example, when you give a bag mask ventilation to this patient, when you press the bag mask, ambu bag, because of the positive pressure that is created, the material is in such a way that automatically enlarges and it provides a perilaryngeal seal. And when the patient expires, it automatically deflates. When the patient is being given a positive pressure ventilation through ambu bag, it automatically inflates and provides a perilaryngeal seal. So that's how they designed that instrument. That's called an AirQ device. That is called a cuffless device. And then you enter the second generation laryngeal mask airways. Why you need the second generation laryngeal mask airways if they are very good? But one problem, what the first generation devices, both this classic, flexible, AirQ, all these things are facing is your gastric insufflation might happen. For example, if this mask, not whether cuffed or cuffless doesn't matter, but this mask, if it is going to expand towards the esophagus also, actually the tip should just reach the esophagus, that's fine. But what if it is actually covering the esophagus and the larynx together? So now when whatever pressure, positive pressure or ventilation you are giving, the air might not enter only into the larynx, it might go into the esophagus as well. So which means there is a high risk of gastric insufflation, positive pressure into the stomach so that it can push the contents out and they might regurgitate back into the pharynx and they might even get aspirated also. So that's why there is a problem that these first generation LMAs faced, which means they did not have any drain tube for the esophagus. They do not have any drain for the esophagus. At the same time, they do not support endotracheal intubation, they do not support bougie insertion, they do not support fiber optic scopes also. Which means there is no drain for esophageal port, esophageal area, so that you, in case if the secretions come to aspirate that, at the same time, they do not support any endotracheal intubation, or they do not support insertion of a bougie, or they support the insertion of a fiber optic scope also. These are the disadvantages of the first generation laryngeal mask airways, which are supposed to be improved in the second generation laryngeal mask airway. So the second generation laryngeal mask airway comes, there are 3 classic devices, and in fact 4 second generation laryngeal mask airways are there. One is the classic ProSeal LMA. Second one is called as Supreme LMA or LMA Supreme, and the third one is the iGel. And you also have this fast track. So before that I can write the LMA fast track. LMA fast track. This is also referred to as intubating LMA. Let me show you in some time. So this is also referred to as an intubating LMA. And finally you have this iGel. Remember, this ProSeal LMA, Supreme LMA as well as LMA fast track are all cuffed as usual. These are cuffed LMAs. But once again, this iGel is a cuffless LMA. This iGel is basically cuffless. Clear? So what are the differences between them? ProSeal LMA, why you need this kind of different devices? So again, insertion of LMA was a problem. That is why this ProSeal LMA came with an introducer. came with an introducer, Prosil LMA. And this LMA fast track again will have an introducer, whereas this Supreme LMA and iGel LMA doesn't come with an introducer. Let me show what is an introducer in the first place. And this fast track LMA, that is intubating LMA, is specially designed for intubating purpose, even though it can be used as an LMA also, but it's specially designed for intubating purpose only. So now let us see like how they look and how they are differing with each other. This Prosil LMA, intubating LMA, Supreme LMA and iGel. You can see this Prosil LMA here. So this is a typical LMA Prosil. So obviously all the second generation devices have one unique advantage. Let me tell you what are the advantages with the second generation LMA, because they are designed to address the disadvantage of the first generation LMA. So which means they can, introduce an endotracheal tube into the ventilatory port. At the same time, they have a drain which can drain the esophagus, and at the same time they can allow insertion of a fiber optic scope also, which can aid you in intubation. At the same time, they can also help you in inserting a bougie, which can help you in inserting a endotracheal tube. So this is the basic things that are seen in all the second generation laryngeal mask airways. Okay, now let us move on and see. As you expect, this Prosil LMA will contain definitely an esophageal drain. You can see it is written as gastric tube here. So which means this port, you have an opening here, and through this opening, you can actually aspirate the secretions through the gastric port. So fine. So number one, and you can apply suction to this tube. You can see this is the ventilatory port, which I'm drawing in green here. So this ventilatory port is definitely supported with an introducer. So this is an introducer that helps in insertion of the LMA better. So this is an introducer, which means the Prosil LMA comes along with the introducer itself. And when you ventilate the patient through this ventilatory port, so the gas will come inside and they're going to leak through the mask into the glottis and into the respiratory tract and the trachea. So this is the basic arrangement of the Prosil LMA, and you can also see that there is a cuff, and this is a cuffed one as well. But one problem they faced with all these three, they faced with this kind of this classic LMA, Prosil LMA, or even a flexible LMA. So what they faced is this cuff might sometimes get kinked. When you are inserting into the pharynx, the distal part of the cuff, it has to go like this, but it can get kinked and like evert like this, so that you have to insert a finger again to put back the cuff and insert into the pharynx. So you will understand much better if you are going to see this video. So let me show you this video, where you can see this is a basic type of LMA only. This is an LMA flexible, so where it is inserted with the help of a finger. But these kind of LMAs, one problem is, as it's shown, you can see there will be a kinking of the distal portion of the cuff, which has to be manually corrected to produce proper positioning. And as usual, now since these are cuffed in LMAs, you have to insert the LMAs, and after that you have to put it with the cuff. Put it with an air to inflate the cuff. Now you can see how these LMAs are helpful in intubating the patient also, because these are second generation LMAs. Second generation LMAs, I told you, they might be helpful in intubating the patient with the endotracheal tube also. So these are the advantages over the first generation LMA. Clear? So we have seen about the Prosil LMA. So to avoid this only, we have gone into the next step of LMA. This is called an LMA Supreme. In LMA Supreme, one important feature that LMA Supreme had is, you can see there is no posterior cuff. There is no posterior cuff, which means there is no kinking. When you are starting to insert this LMA Supreme into the patient, since there is no posterior cuff at all, it cannot kink back, it cannot revert back, so that you have to manually reposition. So that is one modification they did in the LMA Supreme. At the same time, they made elliptical tube. They made the tube more elliptical. So that's the one difference between Prosil and Supreme. Prosil is more of a traditional round shaped tube, but here they made it as a elliptical tube. Still it's a cuffed one only. Still it's a cuffed one, but a slight modification in the cuff came, that is in the form of a absent posterior cuff in these patients. And more importantly, these are molded and preformed. You can see these are molded and preformed, and they are actually semi-rigid. semi-rigid. And ProSeal can be used multiple times, but Supreme and other second generation LMS can be used only once. They are use and throw, only single use. But ProSeal can be autoclaved and they can be used multiple times. Clear? So these are some of the differences. Again, all the other features will be integrated here also. You have a gastric drain. You can see the opening here. You have the gastric drain also. At the same time, you are going to have the ventilatory port also. So all the other things that you have seen in the ProSeal LMA is integrated here also with a little bit of modification, that is absent posterior cuff. At the same time, your body is more elliptical and they are semi-rigid rather than like a tube-like. They are elliptical and they are actually pre-molded and they are like something like a glass. They are semi-rigid, not glass exactly, because otherwise it will some trauma and the airway is gone. So it's not glass. So it's like a semi-rigid structure. So these are the modifications in LMA Supreme. And remember, all these second generation and third generation LMS will have a bite block. So you can see there will be a bite block here in ProSeal LMA. And you can also see this is the bite block, which means this will be located here. Actually, that's how it's designed. So the patient cannot bite. There will be a integrated bite block will be there. And any second and third generation LMA, you can see this bite block. So that's not a important thing here. So this LMA is what we refer to as an LMA fast track. This is another second generation LMA. This is an LMA fast track, otherwise referred to as an intubating LMA. And again, this is a cuffed structure only. There is no, it's some similar to that of a ProSeal only, but this is specially designed for the purpose of intubation. Remember, you can use this as a primary LMA device also, but this is specially designed to aid for difficult intubation. During difficult intubation, when you can't intubate the patient, you can use this intubating LMA as an accessory airway device to aid in intubation. Remember, all these things come along with the package. Again, this has an introducer, like a ProSeal LMA. But remember, the Supreme and iGel and other devices will not have an introducer. But this ProSeal and this LMA Fast Track only comes with an introducer. They have an introducer. And you have a endotracheal tube that comes along with the package. This is a special endotracheal tube that you can use only for this purpose, that comes with the packet. And these are also cuffed only. You can see it's a cuff. You have to inflate after inserting the LMA, and this will be something called a stabilizing rod. Stabilizing rod. So this stabilizing rod is important when you are removing the LMA after endotracheal intubation. Let us see in the video. Because sometimes when you are removing the LMA after intubation, you might accidentally remove the endotracheal tube also. To avoid that, only have that stabilizing rod. So let us see the video, how they do it. So I think it's gone a little bit. So let us start from the beginning. This is how they insert. You can see you have an introducer and they are inserting this LMA with the help of an introducer. And once they have introduced it with the help of an introducer, they are going to inflate the cuff to provide adequate perilaryngeal seal, and that is really important because otherwise air might enter into the esophagus. So providing the perilaryngeal seal is really important. So they does provide a perilaryngeal seal. And after that, again, obviously you have to ventilate. That's the first idea. So they are ventilating the patient for quite some time. So once you have finished ventilation, the primary idea of this fast track LMA or intubating LMA is to intubate the patient with an endotracheal tube. So you have this endotracheal tube that comes along with the packet. So you are going to insert this endotracheal tube into this LMA. So remember, one advantage of this intubating LMA is they can accommodate up to 8 size endotracheal tube. Remember, other second generation LMAs, they cannot accommodate up to 8 size endotracheal tube, 6 to 7 with difficulty, but this can easily accommodate 8 size endotracheal tube. So you have intubated the patient. Now you have to inflate the cuff. Once you have inflated the cuff, definitely you have to check with the capnography to confirm whether the position is right or not. We have a separate discussion of waveform capnography in the subsequent videos, but you can see the cuff is elevated here and you have to check with the waveform capnography now. Once you have confirmed that the tube is in position using a waveform capnography, then you can ventilate the patient for some time. So once you feel that the ventilation is good and the patient is maintaining saturation, now you can attempt to remove this LMA. Now the LMA is not going to serve any purpose from now on. So now you can remove this LMA, but the problem is when you're removing LMA, your tube also might come out, endotracheal tube. So you have to deflate the cuff first and you have to introduce a stabilizing rod. You have to put the stabilizing rod before removing the laryngeal mask airway after intubation is done. So that's the stabilizing rod that's getting inserted into the endotracheal tube. So now after inserting the stabilizing rod, you can remove the LMA. Yes, slowly you can remove the LMA after deflating the cuff. So once you see the endotracheal tube in your eyes, you grab and hold the endotracheal tube. Yes, you grab and hold the endotracheal tube. Now remove the LMA and the stabilizing rod. That's it. So now your intubation is done. This procedure is especially done, this intubating LMA is especially designed for aiding difficult intubations. So that's why this is a special device, fast track LMA. Clear. So now we have discussed about LMA Supreme, LMA fast track and a ProSeal LMA also. What are the differences? All these things will have a drain tube. You can see this is the esophageal drain and this is the drain port in a Supreme LMA. And you can see how they are going to accustom the endotracheal tube also, which means all the second generation LMS will aid you in endotracheal intubation also. They can pass bougie, they can pass fiber optic scope, they can pass endotracheal tube, and they will have provision for your esophageal drain also. Clear? And remember, only one problem. Even though I told you, you can do all these things with second generation LMS, passing this fiber optic scope is extremely tough with LMA Supreme. So why passing this fiber optic scope is tough with LMA Supreme is because of the fact that this is a preformed, isn't it? This is a molded one. This is a semi-rigid one. So this, flexible scope cannot pass that easily because it's a mandatory that you have to follow the curvature only. Sometimes you might not follow the curvature and sometimes it is really difficult to pass a fiber optic scope through this LMA Supreme. Other than that, fiber optic scope, they are designed to, accustom this fiber optic scope only. But only one thing we have not discussed yet is the iGel device. What about the iGel device? So you can see this is the iGel. Here, it is absolutely cuffless. So there is no cuff at all. So what they will have, they will be, the mask will be actually made of a elastomer. So there is a special, material that is used to create this mask, that's an elastomer. So you don't need a cuff at all, which means it automatically inflates and deflates. So they have integrated the AirQ technology here. So it automatically inflates when you give a positive pressure ventilation, it will automatically deflates during expiration, which means during inspiration, it will provide a perilaryngeal seal by getting inflated and avoid the leakage of the air into the esophageal area also. And still they do have a esophageal drain. Yes, there is no doubt about that. At the same time, they will have the bite block also. Remember, all the second and third generation LMS will have integrated bite block with them. So they do have a bite block and they do have an esophageal drain also. At the same time, they don't have an introducer. They don't need an introducer because they are like an elastomer. It's easily flexible. At the same time, they are cuffless also. Clear? So this is the basic principles of a iGel device. So iGel is more easier to insert and at the same time, it's been studied in multiple trials to have one of the fastest rates of insertion. So very fast you can insert this iGel compared to other devices, because I will tell you a trial result which showed you certain differences with devices. For example, what are the differences between your laryngeal tube, then your classic LMA and other types of LMAs and iGel? Remember, correct first insertion, which means correctly you can insert in the first time itself. It's much better with laryngeal tubes compared with that of the iGel and the other LMS. Then fastest insertion, how fast it takes. Fastest is always the iGel. iGel is supposed to get inserted within 16 seconds, whereas other LMS might take a little bit longer time, which means the fastest among all is iGel, only 16 seconds. Others might take 26 to 35 seconds depending on the type of LMS or laryngeal tubes you are using. Clear? So, and again, this pharyngeal leak, the cuff leak pressure is much higher with iGel. So, iGel had a lot of, other advantages compared to that of the standard laryngeal tubes and the other LMS. So, that is why iGel has a special place. And nowadays, many surgeries itself are done under iGel, even the difficult intubation. And when you can't intubate a patient, what I prefer is iGel only. This is a second generation LMA. So this is what we prefer in the current emergency. Okay. Then we had a third generation LMA. Third generation LMA. This third generation LMA is what we refer to as a Basca mask. Basca mask is a third generation LMA. So why you need this third generation LMA? So let us see what is the Basca mask. So this is the Basca mask. So there are numerous advantages with this Basca mask again. So they have rectified some more mistakes also. Remember, even though they provided the second generation provided the gastric drain and the esophageal drain, but they are most of the time useless. Why? Because whenever you try to put a suction through the gastric drain, you create a negative pressure, isn't it? You tend to create, because suction creates a negative pressure in the esophageal drain end. So that negative pressure will suck in the esophagus, or it might result in impinging of the soft tissue of the esophagus into the drain, which will prevent any movement of the fluid, because that negative pressure suck the tissues inside, and you might understand, like, you will impinge on the esophageal wall so that the fluid doesn't come into the esophageal drain at all. So that's a very big headache many times. And many times this gastric drain port or esophageal drain port will be useless in the second generation LMS. So to avoid that and to make it more useful, they created this Basca device, where you can see you have two ends. You can see all this, there is a common gastric sump. This is called a gastric sump. So where the secretions will get accumulated in case if it is there. And you have two openings for the gastric port. You have two openings, isn't it? To the gastric sump, you have two openings. Why you have two openings? Remember, one, you can connect it to suction. And the second will be directly open to the atmospheric air. Open to atmospheric air. Which means I told you why the gastric drain or the esophageal drain is uselessness on a traditional second generation LMS, because of the negative pressure created, and that takes the chunk of esophageal tissue and impinges on the esophageal tissue so that the fluid doesn't come out at all, accumulated secretions. But here, since it's one port, both the ports are leading to the same sump and one is connected to the atmosphere, even if you put negative suction through this port, the atmospheric air will come through the other port and it will push the secretions through this port that you are giving the suction. So this is a very brilliant and wonderful idea. So they made it, and very, very good. So which means the entire concept of this gastric drain itself is changed by this Basca mask. Okay. At the same time, it is also cuffless. There is no doubt about that. There is no cuff at all. And this will provide an excellent seal, and it's more anatomical, the seal that is created by this Basca mask. And at the same time, this also has an expansion and contraction capacity depending on how much positive pressure ventilation you give. And this can serve as a good substitute for endotracheal intubation, which means you don't need to have endotracheal intubation if you have this device. Even it can be used for elective surgeries also. Majority of elective surgeries in abroad, they're using this Basca mask only nowadays. So this is a third generation LMA. And you can see one more beautiful thing that has been given with this Basca mask is that proximal tug. You can have a tug here. You can see this is the tug. So why this tug is given is sometimes this LMAs are very difficult to insert because your oropharyngeal curvature is very curved in some patients, especially in emergency when we are looking up for this devices for a patient who cannot be intubated. So we find it very, very difficult to insert this device because the curvature may be so curved. So to avoid that problem, so this Basca mask gives this proximal tug. So using this tug, what you can do is once you are inserting this device, if you cannot insert any further and if you are finding this resistance, what you can do is you can put your hand and just pull this tug a little bit towards you so that the device will get more curved so that it will easily move into the curvature of the oropharynx. You can see here. So once I'm going to pull this tug, automatically it becomes more curved. So this are all beautiful integrations. A lot of things have come with the Basca mask. And these are the two drain ports you have for the gastric drain, and this is the general gastric sump you have near this area so that you can take it out. And this is the mask through which this is the ventilatory port through which the air comes out. Beautiful, isn't it? And remember, with this device, you don't need to intubate the patient. And no need actually. That is why any textbooks if you take or any trials if you see, they will not tell this can pass a bougie, this can pass a endotracheal tube, this can pass a fiber optic scope. They will not even mention that. Why? Because they don't need that, because this is a substitute for endotracheal intubation in general. Clear? So the third one is the Bosca mask, and again I can put it blue colored here because it is cuffless. Cuffless. Remember, this Bosca mask and iGel has one more unique advantage, is the fact that this Bosca mask and iGel can provide an esophageal seal also. Remember, I am not telling esophageal cuff. Esophageal cuff is a feature of a laryngeal tube. But here I am telling they can produce an esophageal seal, a good esophageal seal, because of the expansion capacity. Clear? Very, very good devices, iGel and Bosca mask. They are the only laryngeal mask airways which have additional esophageal seal apart from perilaryngeal seal. Clear? So very, very important, but still they are cuffless. Fine. So these are the different types of laryngeal mask airways you have. I have first generation, classic LMS, flexible LMS and AirQ. Second generation LMS, you have ProSeal, Supreme, Fast Track, that is an intubating LMA, and you have a iGel device. And finally, last one is the third generation LMA, where you're going to have the Bosca mask. So these are the questions. Definitely, I believe that this Bosca mask will be a question for you. So how will you select the size of the LMA? Remember, classic ProSeal LMAs, all these things, the size of the LMAs is dependent on the weight of the patient. Remember, weight, for example, if it is less than 5 kg, you choose a size 1, which can hold a cuff volume of 4 ml, because these are cuffed, isn't it? ProSeal, Supreme, then your classic LMA, flexible LMA, all these things are cuffed. So they are accumulating a cuff volume of 4 ml. If it is 5 to 9 kg, you are going to choose 1.5 size, which can hold a cuff volume of approximately 7 ml. And then 10 to 19 kg children, you select a size of 2, which can hold a cuff volume of 10 ml. And 20 to 29 kg cuffs, size 2.5, 2.5, hold a cuff volume of 14 ml, maximum cuff volume. And 30 to 49 kg patients, adults usually, cuff size of 3, and it can hold a cuff volume of 20 ml. And 50 to 69 kg patients, you select a size 4 for these patients, and it can hold a cuff volume of 30 ml approximately. And finally, you have 70 to 99 kg patients, where you choose size 5, where it can hold a cuff volume of 40 ml. And you also have LMS for people who are more than 100 kg. You select size 6, which can hold a maximum cuff volume of approximately 50 ml. So these are the sizes of the LMS. At least this you have to know. So this is a size chart how you are going to select the LMS. Remember, similarly, you have size chart for laryngeal tubes also. So laryngeal tube also you have sizes, how you are going to select the size for laryngeal tubes. So again, based on the weight only, less than 5 kg, you select size 0. And you have color coding also. Remember, one of the important advantages of this laryngeal tubes and the modern LMS like iGel and Bosca mask is they have color coding also. Fine. So they are clear color. So that's a color coding. If it's 5 to 12 kg, it is size 1, and they will be usually white in color. If the size, weight is 12 to 25 kg children, the size will be 2, and they will be green in color. And for adults, it's not based on weight, it will be based on height usually. In adults who are 125 to 150 centimeter, you will select 2.5, the color coding will be orange. And in adults who are less than 155 centimeter but more than 150 centimeter, you will select 3, and the color coding will be yellow. And adults who are 155 to 180 centimeter, you select size 4, red in color. And anyone who is more than 180 centimeter, you will select size 5, which will be purple colored. So these are the different color coding. For example, you can see in this devices you have a color coding. You can see the blue color, isn't it? It's a purple color, which means it's definitely for adults who are more than 180 centimeters. So similarly, you have color coding for iGel, and you have color coding for your Bosca mask also. So color coding for iGel and Bosca mask. So let us see for the Bosca mask color coding. So you have a size, you have a weight range of 30 to 50 kg. which use a size 3, which will be green in color, and you have 50 to 70 kilogram people, size 4, yellow in color, and 70 to 100 kilogram, size 5, red in color, and finally you have more than 100 kilogram, size 6 and blue in color. So this is the Bhaska mask color coding, which means among the laryngeal mask airways, this iGel and Bhaska mask is going to have color coding also. Remaining things will not have color coding, but these are given with color coding also. That could be a potential question for your exams. Clear? So these are the different laryngeal mask airway devices that you have to know. Now, after knowing the laryngeal mask airway devices, let us see what will be the differences with the endotracheal tube. So, what are the differences with the supraglottic airways or supraglottic airway devices versus the endotracheal tube? Remember, first thing is the skill. Skill required to insert endotracheal tube is little bit high. Even though it's easy when you're experienced, it's relatively high. You need to learn that. But skill required to insert a supraglottic device is very, very less. Anyone can do. Even a paramedic, if you train a little bit, it's fine. It's enough. You can do it. And second, anesthesia. Usually, endotracheal tube insertion needs a deep anesthesia. But supraglottic airway devices just need a superficial hypnosis. That's all. Nothing. They don't need a deep anesthesia at all. But ETT definitely, there's a lot of things. You need to give a very good muscle relaxant, and it's really, sometimes becomes difficult to insert an endotracheal tube unless and until you have a good anesthesia and a good muscle relaxation. And airway trauma. You all know that endotracheal intubation has a higher risk of producing an airway trauma, whereas your supraglottic devices have definitely a lower risk of producing an airway trauma. And intermittent positive pressure ventilation, IPPV, remember it is limited. It is unlimited. How much ever you want, you can give. But theoretically, at least, it's limited with supraglottic airway devices, which means you cannot give so much of intermittent positive airway pressure, which means there will be some back leak will be there or leakage into the esophagus will be there. So at extreme pressures. So they cannot, they can provide a good cuff seal around the perilaryngeal area, but still it's not designed for this purpose, for the high level of intermittent positive pressure. But any unlimited amount of pressure, theoretically you can give in endotracheal intubation. So which means this becomes an advantage of endotracheal intubation. So these are the three advantages of supraglottic airway devices, but this unlimited IPPV will become an advantage for endotracheal tube. And risk of aspiration. Theoretically higher, even though modern devices have very, very low risk, like iGel and Bhaska mask and all have very low risk, but theoretically the risk of aspiration is definitely much higher than the endotracheal tube, because endotracheal tube provides a very, very good cuff seal around the trachea. Still, there is some microaspiration risk is still there with endotracheal tube. That's the reason why you got a ventilator-associated pneumonia. So, but you cannot tell zero risk, but still some risk is there. But relatively speaking, lower risk with endotracheal tube and higher risk with supraglottic airway devices. And equipment needs very less and simple equipments. You don't need much at all for supraglottic airway device. But equipment needed is more complex. In case of endotracheal tube, you need a laryngoscope, you need probably a bougie, you sometimes need a fiber optic scope. So many things you need to insert an endotracheal tube. And hemodynamic changes. This, I feel, is the most important point. Hemodynamic changes. No, usually it is not as if hemodynamic changes are much lesser hemodynamic changes. There will be no much change in the BP or pulse rate when you are doing a laryngeal mask airway or any other supraglottic airway device. But here, definitely yes, a lot of hemodynamic changes will happen because it's more stimulating compared to that of the laryngeal mask airway and laryngeal tubes, that is supraglottic airway devices. So these are the basic differences that you have to know between a endotracheal tube and a supraglottic airway devices. Clear? In general, I feel this hemodynamic changes will be definitely an exam question probably. So they will ask you like true or false statement only. That's why I'm telling all these tables. Otherwise, why should I tell? Fine. So now let us compare and contrast about the oropharyngeal airway, nasopharyngeal airway and a supraglottic airway device. So all these things. So remember, oropharyngeal airway is easy to use, very, very small and cheap, extremely cheap. So this is the pro. You have a lot of cons also with oropharyngeal airway. Definitely very, very high risk of aspiration. Clear? So they do not provide any protection to aspiration. So definitely high risk of aspiration. and suctioning is very, very difficult. Especially oral suctioning becomes a hell of a job with oropharyngeal airway in situ. Oral suctioning is extremely difficult. Clear? Contraindication, a patient who is having extensive oropharyngeal trauma. I mean, only relative contraindication, extensive oropharyngeal trauma, especially if you cannot see where is the mouth, where is the tongue, extensive oropharyngeal trauma, and if the patient is having positive gag reflex, very, very difficult. You cannot, in the presence of gag reflex, if you insert, they will vomit and they will aspirate the content again. Definitely don't do it. Okay, nasopharyngeal airway. Compared to the oropharyngeal airway, they are well tolerated. They don't stimulate the gag reflex. That's why. Well tolerated. And as I told you, it can be used in patients with the positive gag reflex also. Remember, positive gag reflex is a contraindication here, but you can use it here. So that becomes an advantage. That becomes a pro here. And again, similarly, it is easy, small, cheap. And here, your oral suctioning becomes difficult. Yes, here you can do oral suctioning. Here you can do oral suctioning. So these are some of the advantages of nasopharyngeal airway. Remember, again, there is a high risk of aspiration and clogged with mucus. Sometimes in the nose, if you have mucus, it can be clogged. So again, contraindications only two. If the patient is having significant epistaxis, you cannot do this. At the same time, in a patient who is having a suspected head injury, you cannot use this nasopharyngeal airway because it may potentially, hide your view from seeing a CSF leak or a blood leak from the nose. So you cannot do it in head injury. Supraglottic airway devices. So better protection against aspiration. Better protection against aspiration compared to these devices, but still not the best compared to that of intubation. But still they do provide a very good protection for aspiration. Your bag mask ventilation, that's called BVM, becomes very, very easy. Bag mask ventilation becomes very easy. Clear? Bag wall mask in the presence of a laryngeal airway. And air leak will be very less. Remember, with oropharyngeal airways, even if you give a BVM, bag wall mask, the air leak will be significant. But here, air leak will be extremely less because you are doing in a targeted way. Through the particular tube will be there in the supraglottic airway devices. Through that only you are bagging. So the air leak will be much lesser and they provide a good perilaryngeal and esophageal seal if you are having a correct type of a supraglottic airway device. And again, less risk of gastric aspiration. Lesser risk of gastric inflation compared to oropharyngeal airway. But cons, it's a little bit more bulkier compared to these devices, expensive, and sometimes if they are inflatable, it might be more time consuming. It might take a lot of time because they need even 20-30 ml of air to inflate the cuff. So might be more time consuming. And again, gag reflex definitely becomes a relative contraindication for inserting these devices because in the presence of gag reflex, again, it's very difficult to insert this device. You need some sort of anesthesia. You have to suppress the gag reflex, then only you have to insert this device. Clear? But again, this has been proven with Bhaska mask. Bhaska mask can be inserted by yourself. So actually, a lot of people have demonstrated that. So it is one of the devices, I don't know, the material is in such a way, it is so smooth and flexible, it will not stimulate the gag reflex that much. And many videos are there where there is self-insertion of Bhaska mask. So again, there is that is a different end of a spectrum. We are not going to discuss about those. So these are the pros and cons and contraindications of a oropharyngeal airway, nasopharyngeal airway and a supraglottic airway device. I think we have done a very decent job on supraglottic airway devices and the basic airways. In the next section, we'll be discussing on the endotracheal intubation.